Once again, I'd like to welcome everyone to Podiatry Practice Mastery. Today, we're going to be talking about plantar fasciitis treatment protocols. This is something that all of us see on a daily basis, and I'm going to give kind of my impression of it, but I'm not saying that's the same for everyone. Before we start, though, I want to talk a little bit about Podiatry Practice Mastery. This group was started by Jim McDonald and myself, and we did it basically to help you increase profitability, efficiency, and accountability. And with COVID and everything that was happening, we just weren't able to get to the meetings. And the part of the meetings these meetings, continuing education meetings, we always enjoyed most were the kind of camaraderie and talking about business tips and practice management tips. So I would love it if you kind of wanted to put something in the message box, or you can email me afterwards. You've been getting the emails. You can just tell me your thoughts. What we do with Podiatry Practice Mastery is basically we do interviews, and this is where I do one interview a week, and it sends it out through podiatry.com. They're just the ones that send it out to their list. That's probably how you heard about it. I also do a podcast where I put the interviews on the podcast, and then I might talk about like different questions I get from other doctors. There's a little newsletter that we put together, an application and action component. That's the part that I like the most, is the application and action, basically how you can apply this to your own practice. And then there also is a membership portion on the website. There's free memberships. Eventually, there's going to be paid memberships for those that want to get more help and get better results quicker. If you want to download, if you're watching this afterwards, if you want to download your worksheet, you can do it right here. Basically, just use the QR code and you can click that. It'll take you to that form, or you can check your email, or you can email me and I'll send you this worksheet. So let's get into this. What we're going to talk about today is plantar fasciitis treatment protocol. And then the thought is at the end, if anyone wants to contribute or has any other thoughts, then we can talk about it together. Okay. We are going to talk about what I've named the treatment stages, which is the before, during, and after. We're going to talk about the visit categories. We're going to talk about checklists. And then we're going to talk about different packages. I don't know if you guys have a tendency to use packages, but what I do know is that everyone here is treating plantar fasciitis, and I do not presume to be the world's greatest master at plantar fasciitis. Okay, the whole idea of mastery or having a mastermind is learning from each other. I want to tell you a little bit about the backstory behind this, and I'm going to stop sharing this for a little bit as I talk about this backstory. The backstory behind working with these ideas aren't only from me. Okay, what I found with treating plantar fasciitis and with treating other types of issues, you need to learn different techniques and different tips. And a lot of them I found from the American Academy of Podiatric Practice Management, reading Podiatry Management, and a lot of other types of sources to improve. And we're just constantly improving and trying to work on better ways of doing things. This whole framework of before, during, after, I'm stealing from I Love Marketing. If you guys want a great website to learn more about marketing, it's I Love Marketing. And they talk about that framework of before, during, and after. And the reason I've divided things into categories is I thought it was very complex, and I tried to simplify it by dividing into categories. And we're going to go through these categories, and you guys can chime in different aspects. We're going to talk about DME and office dispensing, things that work for you. But even with that, I found it was way too complex. And that's where I started to use this idea of a checklist. And I don't know anyone else that's using a checklist. If you guys use it, let me know. But I found checklists have almost been, you could call it my savior. It's like the best thing about treating patients is now using a checklist. And if you only take one thing away, I hope you might want to consider using a checklist slide for your patients. And I'll give some examples. So checklist makes everything better. So I'm going to go back and share the slides here. So let's start and talk a little bit about this. Now, if you guys want to put something in the chat, you can. The treatment stages. So the before stages, before the patient comes in to see you about plantar fasciitis. There's a lot of things that you can do, but in my experience, and probably yours, I have patients that come in every single day, and they may have been referred from their primary care. Those are the ones that are so-and-so, okay? They come from the primary care, the ones that Google me on YouTube or Google you on YouTube or in your local community. They come in before. But by far, the best patients are the patients that would watch, let's say, an hour webinar, or they would read one of your books, and they're totally educated before they come in. Those by far are the best patients. So as many of our patients in the before stage that we can get them to learn as much as we can about the condition before they come in, it makes it a lot better. And patients are learning online whether we want it or not. They're going to be Googling it. They're going to be looking at all these other resources. So my thought is we have to have the best information out there, and preferentially even on our website. So I'm going to give you a few thoughts of the before stage. So before they even come and see you, one thought is when a patient comes and makes an appointment for plantar fasciitis, your staff sends them, say, Dr. Pelto wants you to go to our website and we have a webinar on plantar fasciitis. Why don't you watch before you come in? Now, I know a lot of doctors think, oh, I can't give away everything. Well, the patient isn't going to have their own treatment. And the more things that they try initially, the better, because they're going to be more and more frustrated. So one thing would be doing a webinar. If that's too difficult, you can do a little ebook. There's a lot of different ways you can do it, but giving them information even before they come in can be very helpful. Blog articles, things like that. Other patients come in specifically from an AdWord campaign. We're not talking specifically about that, but if you're advertising for AdWords, you can then send them to one of your videos. You can send them to one of your books. But once again, the best patients are the ones that are pre-educated about the condition before they come in, or they've been frustrated with seeing another doctor and they're not getting better. Okay, they don't just want another shot, or they don't want to have their orthotics adjusted every week. Okay, those are some of the things that we see around where we live. The during visit I want to talk a little bit about is this is the actual during the appointment. And this phase starts with our front office staff in terms of giving them a good experience, welcoming them, doing all the preliminary paperwork, chief complaint, history of present illness, the treatments, and the x-rays. Everything is all set out for a plantar fasciitis patient. I know you guys all probably do that, but everyone comes in having a x-ray done on them. Everyone comes in having all these questions. And the issue is with the first visit, this is something that I've only changed recently, but on the first visit, I tend not to do treatment anymore. And you may think, oh, we have to treat everyone the first visit. I find that the more that I listen and the more that I do reflective listening and repeat what they say back to them, the more I can make a plan for them. Now, occasionally, let's say they're dying in pain, I may still use like a cortisone injection or something else like that. But for most of my patients, I just listen and I say, okay, based on this checklist that I'm going to show you a little bit later, this is what I think would be best for you, Mrs. Jones. How does that sound? Okay, that's what I do. And that's only been recent. Up till like months ago, I used to be trying to see them, listen to them, teach them, and then do all these treatments the first visit. It just got way too overwhelming. So we're going to go a little bit more into that when we talk about the during component. And then there's the after component. And this is the part that I think that we can really excel. And this is providing follow-up to them, having a plan of what comes next and setting out a plan of care for them, having automated follow-up. Using technology these days, it's really easy to do automated follow-up. One of my favorite companies, and now I don't earn anything from them, it's called Patient Education Genius. And basically every patient that leaves my office, it connects into my medical record, which is Athena. It sends them patient education information, whether it be that video I was talking about, that webinar, that book, and then I send it to them, and it also bugs them a few times. So if they don't open it, it'll repeat it 2 or 3 times back to them. But there's also an added bonus to Patient Education Genius, is that it'll ask them for an online review. And it automatically automates that process of doing online reviews. So that's why we get so many online reviews. And then another portion of the after visit experience, this is just a practice management thing. I know many of you probably do this, but for new patients, we like to send them like a thank you letter from the office or a thank you card. No one does that. It costs maybe $1, but it really makes a difference if we thank them for coming in. And then I'm sure you do this as well. When we do surgeries, we call them, either the day before or the evening of surgery, just to make sure that they're doing all right, making that a process. So those are the treatment stages. I want to go now into the visit categories here. Now, if you look at your worksheet, and once again, I did put the worksheet in the chat section, and we're going to talk about these different categories, and we're going to talk about different tips. Now, if anyone wants to chime in or put something in the chat box, I'd love to hear back from you. The first portion is patient interaction. So patient interaction, this is how we encounter the patient when they come in for plantar fasciitis the first time. This is the way I do it. I don't know how you guys do it, but I always welcome them to the office and I introduce myself. I say, hello, Joan. I'm Dr. Pelto. You can call me Don. Thank you for coming in today. That's a good way of introducing, we can't shake hands anymore. We're wearing masks due to COVID, but we can also, we always can welcome them and make them feel at ease. And that's something that versus just coming in, and a lot of doctors, they really don't have any bedside manner, but just by being nice, we can go a long way with our patients. Then the next portion, I say, well, how did you come in? Ask them kind of who referred you. Was it the internet? Was it a primary care doctor? Even if they did come in from the internet, I always ask them, well, I came in from the internet because that's how people are coming in. I saw your Google reviews. And then I would say, wow, yeah, there's some great reviews there. But then I asked them, well, who's your primary care? And inevitably, we always see those primary care doctors referring patients. And then I say, I see a lot of patients from Dr. Jones. I think we can help you out. Always kind of trying to encourage them. Say, I see a lot of patients with plantar fasciitis, encouraging them, knowing that they're in the right place for what they're dealing with. And I'm a big believer of that first visit of getting to know the patient and of spending some time with small talk, just asking them about their family, where they're from, telling about your family, where you're from. I think that's real important because a lot of times we don't leave ourselves enough time. We have like a 10-minute slot for a plantar fasciitis patient, and you can never really get to know them. I think especially the first visit, we really have to make that bond, because if we don't, everything else that comes after is going to be more challenging. If you're rushed, if you're running behind, it just makes it a big challenge. Also, I ask them just to tell me their story. That's what I do. I say, tell me what's going on. Tell me your story in your own words, because they might not know the right word. They probably don't know how to pronounce plantar fasciitis. But by listening to them, I think that's very important. But not only that, is when we listen to them, then I actually mirror it back to them. I say, okay, Mrs. Jones, so it sounds like you've had this for about 3 months. You're frustrated. You've tried some icing, you've tried some anti-inflammatories, you tried some inserts, but nothing's really working. That's why you're seeking me out. How does that sound correct? Repeating it back makes them feel that they've been heard, and then they'll add in other aspects that you haven't talked about. And a quick tip that I learned at one of the Podiatric Academy AAPPM meetings is if they come in with like 500 problems, they'll come in with fungal toenails, they'll come in with plantar fasciitis and everything else, and they want you to treat and deal with everything that day. I always ask them, what's the biggest problem? What's the one that you want to treat the most today? And the other ones we'll deal at another time. And that might not be a separate visit. It might be just at a follow-up. Let's say I'm doing a shockwave, then I can deal with the nail at that time, the fungal toenail, taking a nail sample. But we get bogged down trying to do everything. But what they really want to do is to be led. And it's best to treat one at a time because we don't have a ton of time. Also, when they're telling the story, I like them to explain what they've tried before so they can kind of share their experience. And I go over that with them. And there's 3 really big questions. And I learned this from Paul Holbrook. He's from the United Kingdom. He does a lot of shockwave training. And this has really just revolutionized making this connection with patients. And his questions, and I'm stealing it from him, what are the 3 things you can't do because of your pain? And this is really important because a lot of times they can't play with their grandchildren. They can't be as active. They're gaining weight, so I can't lose weight. That's really getting down to what the problem is. So that's the first question. And I'll show you guys on my slides later on how I do this. What are the 3 goals when you're pain-free? Like, what do you want to do? Maybe it's the same thing. I want to lose weight. I want to get more active. I want to play with my grandchildren. And then what's the meaning if you achieve these goals? Like what that's going to do for you. And this is getting them connected to a future. They're going to get involved in a future that's inspiring to them and that they're excited about. And that's something you want to do because basically what you're doing is you're giving patients hope. That's what we're doing. And a lot of times what we say, they might think, oh, this is the first time that they've ever seen this condition. No, I just want to reassure you, I've seen this many times, many people just like you, and we're very good at getting people better from this condition. So that gives them hope. And then I always say during this first patient interaction, I want to go over 3 things with you today. I want to talk about what you have, why you have it, and what it's going to take to get you better. How does that sound? And I always, if you notice, I'll tend to end things like, how does that sound? Or what do you think? Or how's that? Because that gets them, in agreement. Because a lot of times patients can come in and they've maybe seen two or three other doctors. They're on the defensive. They're scared. They're unsure. They're maybe not even be listening to you because they're thinking they're going to get a shot in their foot. But when you talk to them this way and get these positive kind of yeses in the beginning, it makes it easier as you're starting to talk about the patient plan. So I'd encourage you guys to write on that paper that I gave you, that Google Doc. You can put any other ideas, what works really well for your patient interactions. The next part is imaging. In terms of imaging, the main three things that we use are x-rays, ultrasounds, and MRI. One thing I've learned in practice, we used to do three views of the foot. Now I do 2 of the foot and 2 of the heel. It's an extra image, and that's kind of how we do it here. Once again, insurance covers x-rays, and we'll do it at different portions, but usually not multiple x-rays for plantar fasciitis. A good tip is for going over x-rays, patients love having their phones these days. And we used to always have to print out CDs. Now what I do is I say, Mrs. Jones, would you like to just take a picture of your x-ray? And they love using their smartphones, and they'll like pull it up and take a picture. I might mark something on my digital x-ray. So that's one thing, they can take it. Now you might, I'm going to break HIPAA. Well, it's their own image. So they can break HIPAA if they want, but I'm not doing that. They are. Okay, they can take a picture of their x-ray. Another thing that I do is I have as normal of an x-ray that I could find of an AP and a lateral in every treatment room. It's laminated. And so what I do is I pull up, let's say the laminated one, just an example, a laminated one, and I show them on their x-ray. That makes it a lot easier for me to show if they have a big bunion angle, or if they have a big heel spur, or if they have a low arch, and I can compare that. This is a normal x-ray. This is your foot. Do you see the difference? They can see that a lot more than just looking at their x-ray. Those are some tips in terms of for using x-rays. Ultrasound, all of my patients that have plantar fasciitis, they're getting an ultrasound. It's usually not at the first visit though. What I say is and this is how I use my presentation. I'll show them a picture of the ultrasound, and I'll show them the thickness on my PowerPoint. We'll go over that in a little bit. This is the thickness of a normal plantar fascia. This is a thickened fascia. And sometimes they ask me, is that my fascia? And I said, no, that's just a picture, but we can do an ultrasound later. Now in my area, ultrasound normally isn't covered in Massachusetts. Medicare might be covered, but a lot of insurances it isn't. So I just charge $100 per ultrasound when I do that for my patients. And once again, with the ultrasound, and I usually do that the next visit. So what I say is Mrs. Jones, an x-ray is helpful, but I really want to see the thickness, because a lot of times it's been scarred or thickened over time and been chronically inflamed. And we'll compare the right foot that hurts to the left foot. And I'm not going to charge you for the left one, but the right one, it's usually $100 if insurance doesn't cover it. That's really a non-issue. And then at the follow-up, I have them try some things, and then I do that at the follow-up all day long. Another reason I use ultrasound, let's say after I do a course of shockwave, I'll do 4 to 6 sessions of shockwave. And then at the 6-week follow-up afterwards, I'll do a follow-up ultrasound. Now that ultrasound, I don't charge them for. I just you might charge them for a second one. I just figure if they're doing one, I really want to show them the difference if there's reduced inflammation in that fascia. And then the third thing is doing an MRI. For MRIs, I don't do them that often now that I have ultrasound, but occasionally if I'm concerned of a rupture or something isn't getting better. The next thing in terms of visit categories I want to talk about are procedures. Up till maybe 3-4 years ago, my main procedure, like everyone else's, was probably a cortisone injection. And I got good results with that because that's the only thing I had. And I did, I'm not one that does one every 2 weeks. I did it as needed. And now that I have ultrasound, I think I'm better at it because I do them with ultrasound guidance. And just a word to the wise, you can't bill an ultrasound exam and an ultrasound guided injection. You kind of have to pick one or the other. Usually it's the exam that I'll do. And that's what I do. Or if patients, once again, they don't have insurance that covers it, I'll just charge $50 for an ultrasound guided injection. I think it's better. I would want mine done by ultrasound guidance because I'm much better at getting it in there. But I don't do cortisone that much anymore. And I can kind of explain on the checklist how I explain that to patients in a little bit. But I tend to say, we could do cortisone. It tends to be pretty harmful to the fascia. It reduces the inflammation very well, but it doesn't really heal things. And a lot of patients are preferring to these other types of procedures like shockwave. We have both a radial and a focused device in our office, and we do them both in conjunction. Everyone likes to talk numbers on these lectures, so we charge $150 per session. I start patients with 4 sessions once a week, and then I see them at 6 weeks after, and then I might do a couple more sessions if needed. And that's the procedure that we do in the office. We also have amnio. We do ViaFlow, which is a right product. I think it's very expensive. I know there are others that are less expensive. Once again, I do not do a lot of amnio. I'm sure there's other people. I've interviewed Dr. Bromley, and he does it pretty much for everyone with ultrasound guidance. He's able to get it for a lot less, and I think he just keeps it at price because he gets such great results with it for that regenerative aspect. And there, I do have one of my videos or one of my interviews with him, and he talks about that. So if you want to watch one of the other ones, you can find that more about using amnio. And then one of the other procedures sometimes we do is like strapping the foot. I don't do it a ton. I find it's hard to get it covered, and I usually just let physical therapists do that because you have to kind of choose what you do. So those are some of the procedures. The next thing would be prescriptions. I don't do many prescriptions. Once in a while, a patient will ask me for something like Motrin or ibuprofen at an 800 milligram dosage, Voltaren gel, something like that. Maybe you guys do more prescriptions, but I don't do many prescriptions. Let's get into durable medical equipment. There are a lot of different things you could use for plantar fasciitis. The ones that I find more commonly give out are night splints, cam boots, orthotics, and sometimes like not quite an ankle brace, but one of those like prefab AFO things. I'll do that if there's a lot of pronation and traction on the posterior tibial tendon. And my thoughts to you is if you're not doing DME, you should start slow, like start with cam boots or night splints that you'll get off the shelf. If you are doing them, it's great. You have to really be careful in terms of billing because of this whole new thing with same or similar. But what I find is with my checklist that I'll show you in a little bit, patients are asking me, I go through, okay, we've done this and this and this. And the patient said, well, we haven't done the cam boot. Can I do that? And I'm like, okay, yeah, we can do that. Or I haven't done a night splint. What's that used for? And I'll explain it and go through it with them. I think a lot of times with plantar fasciitis, like we've been talking about all these things, there's so many treatment options. And it's better when you have kind of, okay, this is kind of like this smorgasbord. This is, we used to call it when I was living in Illinois, this is old country buffet. Like these are all the options. But patients get overwhelmed, and that's where they need our kind of guidance for that. Another thing is in-office dispensing. By the way, about DME stuff, orthotics usually aren't covered by most of our insurances, and we charge $550. We have one of these 3D scanner. We use Forward Motion. Once again, they don't pay me. I like it. Works really well for scanning them, and we get a good product back. We've used some other ones in the past. And for in-office dispensing, there's different over-the-counter inserts. You can use like a heel cup. There's something called an air heel, which is basically a belly of air that goes underneath the foot and goes into the back of the calf. And now let me talk about this. I struggled with this in the beginning because there's so darn many things you can sell people and offer them, and you just don't want to be like a used car salesman. Okay. So I don't do any more air heel. Occasionally I do a heel cup, one of those simple plastic ones. I give it away more than I sell it. You know, a lot of these things I'm giving the pads away. I usually say I'll give them the first one if they want to buy like 10 of them, they can buy the pads. But these cups help sometimes with certain types of heel pain. I don't do it for everyone. And we don't do over-the-counter inserts. We only do custom. The reason I only do custom is that's the only option I have for them. And if I believe they need a custom, I'll give them a custom. And usually it's due to some type of biomechanical issue or helping with posture or heel alignment, okay, and taking pressure off and strain off the foot. But we do a lot. I don't know if you guys do this. We do a lot of foam rollers, and those are like rolling sticks and balls, like deep tissue balls to the calf. So we use Trigger Point tools, and we just sell them in the office. There's a couple of other brands. I think Trigger Point is getting out of selling things in the office, but we do that all day long. Basically, everyone gets their home therapy routine, and then they also go to physical therapy. And my recommendation for doing in-office dispensing is you got to do what you enjoy, you know, and what you believe in. If you don't believe in it, like I don't believe personally in like the CBD oil stuff that everyone's selling. I just don't believe it. I don't use it. I wouldn't offer it in my office, but the foam rolling stuff I do, and orthotics I wear, you know, I have them and things like that. And so you have to do kind of what you believe, and that just makes sense because you don't want to just offer all these things. And it's confusing because patients don't want to come out and say, oh, he's just trying to sell me all this stuff. That's just not a good thing. So I'm hoping you're writing things down in that worksheet that I gave you, some thoughts that you may have or questions you would have for later on. Referrals. This is where I spend a lot of our time because we make a lot of referrals when patients come in because it's usually a team. You need a team of people. The most common one, like everyone else, is physical therapy. So we have some great physical therapy places. They also know I've educated them about shockwave and about orthotics. So a lot of times I'll recommend it to a patient and they'll kind of reinforce that need. They'll also know the types of shoes that I recommend. I recommend a lot of shoe stores as well. I think everyone is in shoes that are too narrow in the front. So we recommend a lot of anatomic shoes such as Lems, Ultras, and Topos. Even for plantar fasciitis patients, sometimes they can't handle the zero drop because of their equinus or their tight heel, but we'll do a lot of anatomic, like a Topo has a very wide toe box in it. And there's some other ones, there's some Asics and things like that that are kind of wide. So that's a referral place. And I actually give them a referral. So I print it out, put in the type of shoe that they need, and it feels like a real referral. Physical therapy, same thing. They print the actual referral. And then occasionally I'll do like massage therapy, or occasionally I'll do acupuncture, but very, very chiropractic, very, very rare. And it really based on situation. And then the last thing in this category would be patient education resources. I think that's fundamental, is teaching your patient, whether you teach them before they come in or you teach them while you're seeing them, or you give them something after, because they are not going to remember after they leave. This is what happens to me. They come in and, I talk about their heel pain, and the real question in the back of their head is, am I fat? And when they leave, all they can think of is the doctor said I'm fat. And even if they ask that question, I say, I have skinny people and heavy people with plantar fasciitis. It's not that. But they'll remember what they want. That's why giving them some type of a resource can be very helpful with patient education. And once again, I do Patient Education Genius. I do have some print books here. Here's one right here. This is one on Achilles tendonitis. So this is real easy to print. I can explain this to anyone. I did this on Amazon. They have this. You can do it on their books. You make a little PDF. You have someone in Fiverr set it up, and you print it, and it looks pretty professional. I don't usually sell them. I just kind of give them to my patients if they need them. It makes it kind of look better, more professional. Now, the point that I referred back to multiple times was this checklist. And I'd like to go through, if there's one thing that you guys could take from this that it might help, this has been a practice changer for me, is this checklist. So everything I talked about, I basically included here. And you'll see I've divided it into categories. And there's an imaging category. I call it traditional treatments, and then advanced treatments. And so the way I use this with patients is I'll show them a first slide, another slide. I think it'd be better if I actually showed you guys on my actual, on a different slide here. So let me pull this up. I'm going to actually pull up my actual presentation. So on this presentation, here it is right here. Okay. Can you guys, am I showing my screen here? I'm going to share my screen right here. Can you guys see this? I think you can. Jim, tell me. The way I use this, if you look here on the side, you see how it says patient presentations? These are all the presentations that I use. So this is kind of what's made my life a lot easier. So for example, I was talking about ultrasound. When they come in for an ultrasound visit, I have this presentation, and I use ultrasound for all of this. So instead of just showing them the ultrasound, what I do is I have this one on plantar fasciitis, and I click it, and I can go over them. I say, okay, Mrs. Jones, usually your fascia is about 3 millimeters, and we're going to look at it. Here's a normal thickness. Here's a real thick one. Okay, this is how I use these slides. But the slide I really wanted to show you was my plantar fasciitis. Now, just so you know, I didn't do this. I paid someone at Fiverr to do it. I'd be happy to, you guys, if you wanted to try these. I use Google Chrome, right? Just so you know how this works. I use Google Chrome. I'm logged in at every computer that I have in my office. And when I log in, I can pull up these because I can pull up all my junk that I have here, my email, anything. So the way I show this to patients is after I do my initial conversation with them, I say, we're going to talk about plantar fasciitis. This is about where you have it. What are the 3 things you can't do as a result of your pain? And they kind of tell me, okay, real important. What are your 3 goals when you're pain-free? And what will it mean to you if you achieve these goals? So those are the kind of my intro questions to them. I think those are important. I asked them how long they've had symptoms, and if it's less than 3 months or greater than 3 months. Because in my opinion, if it's greater than 3 months, it takes a little bit longer. And then they'll tell me kind of what they've tried to treat it with. Okay. And then I'll ask them how it affects their life, things like that, and then what we'll go over. And these are the same things I just talked to you about before, but I put it on slides basically because I want to go over the same presentation every time with my patients. And what I used to do is I used to do the 5-minute presentation. I had 5 minutes, or I used to do the 20-minute if I had 20 minutes. Then I go over a little bit of the anatomy. And basically, I talk about the Achilles, how it pulls. I don't have to go through this with you guys. You guys know all this. I talk about the anatomy. I say, the diagnostic test we did today is an X-ray, and we'll probably get an ultrasound. And I show the difference between normal thickness and a thick one. Now, this slide itself has allowed me to do ultrasound on pretty much every one of my patients. This slide itself. I say, okay, Mrs. Jones, we're going to do this at the next visit. And they're like, okay. I like this one. I got this from Dr. Bromley, and he said, you have 3 options. You can ignore it, hope it goes away. You can do conservative treatment, or you can do surgery. And, they've been ignoring it long enough. They probably don't want to do surgery, nor do we. And then you have the conservative treatment. Okay, that's what we're going to do today. This is where I show my checklist. Now, I used to, and I've learned, because I used to show people pictures, and I can show them. They're right in here, actually. Reduce inflammation, shockwave, amnio, reduce tightness. Now, I used to do this, but it was way too much. So I stopped doing it. So I don't recommend doing it. What I do now is I show them this, and this works a lot easier. Now, if they have individual questions, I'll go over that, or I'll give them a video for that. I'll say, I've recorded my whole plantar fasciitis kind of thing, all the different things with them. But this really has made me very much more effective at treating plantar fasciitis. Not so much the first visit. This checklist has made it more effective, like when they're in like the 7th or 8th time and they're not any better. Okay. And so what I do the first visit, and I basically say, okay, Mrs. Jones, we did an X-ray today. Next visit, we're going to do an ultrasound. We're going to try some things. We're going to do an ultrasound to see how thick the fascia is. How's that sound? Okay. Once again, how does that sound is a lot better than what do you think? Okay. How does that sound? They're pretty much, oh, that sounds good. They're going to do it. Okay. We usually don't need MRIs because they're quite expensive. Okay. But an ultrasound is pretty reasonable. Then I go into the treatment options with them. And I don't always go in the same order. Okay. Depending on what's the biggest issue for them. Like most of my patients, it's equinus. And so I say, okay, Mrs. Jones, I'm going to set you up for physical therapy, but it's only once or twice a week. And so you're going to need to do some home therapy. And that's where I'll either give them the foam roller or an MB1 or MB5. These are different balls that they use for loosening the back of the calf. This is their home therapy. And I have videos that go along with this as well that I share in Patient Education Genius. Okay. Occasionally I'll do night splint, not usually the first visit. But as they come back and they're having that morning pain, then I'll say, well, maybe we want to do a night splint. I also talk about supportive shoes. I always change shoes first. If they're wearing crappy shoes, I'll recommend shoes. I recommend UFOs. And then I also recommend custom orthotics, depending if there's a biomechanical issue with them. Okay. Then I go over these 2 issues. This is where I spend some time with my patients. And this is where I think a lot of you spend your time. You're going to talk, well, do you want to reduce the pain or do you want to repair and heal it? And this is where I go have the shockwave versus the cortisone conversation. And what I explain, a lot of times I'll put them in a boot with the cortisone, but and in the past, I didn't really do it that much. But for cortisone, I don't do much anymore. But the way I explain shockwave is I say, basically, you have a problem in your foot. It's been there for over 3 months. It's not getting better. Normally, when we get pain, it injures it, and then the pain goes down as it heals. Yours is kind of stuck in a chronic condition. And so what I need to do is I need to get that chronic inflammation down. Cortisone is a way, but a lot of times it doesn't heal the tissue. What I find is more effective is something called shockwave therapy. Have you heard about it before? If they haven't, I'll say, well, have you heard of lithotripsy? And that's what they used to put people in water and they shoot sound waves at them. Oh yeah, I've heard of that. So what I do is I shoot sound waves at your foot to the area where it's inflamed, and it actually hurts it more. But then over 6 to 8 weeks, it's able to heal it. So it heals itself by increasing the blood flow. The only thing is you can't take any anti-inflammatories during the recovery period. It's a series of 4 treatments. I do between 4 and 6 treatments. I set you up for the first 4. That's what I recommend today. Okay. That's how I use that. So this has really helped me. But where this really, really comes in is when patients come back like the 10th time. And then I can go over, okay, we've done X-ray, we've done ultrasound. Maybe we've done the cortisone, we've done, I'm sorry, the shock wave, we've done this, and they haven't tried some of the other things. Well, have you done custom orthotics? No, I haven't done that. Well, I think that's next. Or, they asked me, I haven't tried a walking boot. How does that work? Well, let's put you in one. And then we go down to the advanced treatments. After I check all these off, then if I need to, I'll jump to surgery or even a second opinion if I'm not sure what's going on. Okay. And so that's how I use it for my patients. And that's kind of, and now I did talk a little bit about packages. I'm learning this. I am not the expert at doing packages, but the whole thought behind packages, I'm going to stop this here as we talk a little bit more. The whole thought behind packaging is like kind of like when you go and buy a car. They don't ask, well, getting power steering is 200 extra, doing heated seats is 300 extra, doing this is so much extra. Like doing it piecemeal, that really doesn't work all that well at the car. And so what I'm learning how to do is I'm saying, well, we got this package. If you want it, it kind of is everything you need for the next 3 months to get you better, and you can determine how much you want to charge for that. In my experience, as I've been kind of looking at the numbers, I've found that, well, it takes some people about 3 to 6 months to get better, and they spend around $3,000. And I find having that initial conversation when we first meet, I tell them, Mrs. Jones, you've had this for a long time. It usually costs around $3,000 to $5,000 to get people better. And they're like shocked. And then what I do is I say, well, you're not going to have to pay that all right now, but I just want you to be aware, because these things, they are expensive. And I do tell patients that things are expensive. I think some people say it's not cheap, but I've learned from someone else that it's saying it's expensive works a little bit better with patients. So having that candid conversation with them. So that is kind of what we were talking about. Once again, I sent you guys, there's a worksheet. I'm going to repost it here if you want to fill out this worksheet. But now is the time where we can have any collaboration. If anyone wants to open up their microphone and kind of tell them what works for them, or what they've found that's helpful, or what other things that you guys have been doing. If you can unmute yourself, I think you guys can unmute yourselves. Allow participants. Yep, you guys can. Well, if there is no participation or you guys want to talk? I think we don't have many people here. Anyone want to say anything? Want to write anything? Was it beneficial, not beneficial? Okay. Well, I want to thank you guys for your time here today. For those of you that couldn't watch the whole thing, we are going to put a replay of this up on Podiatry Practice Mastery. So you guys can watch the replay if you want, and I'll put some of my notes there. Okay. No one's really saying anything, so it's kind of awkward to sit here. If anyone wants to unmute yourself, you can. Okay.
Hello?
Hi.
Have you heard of cold laser therapy? Like there's a company called Sumus Laser.
I've heard of a number of cold lasers. Yes, I have. How has your experience been with your cold laser?
It's just about 60 to 70%. So it depends on patient compliance, and for the patients that are compliant, it does take about 6 to 10 sessions twice a week for a number of weeks or so. So yeah, it's all about compliance, and so that I've tended to use that versus injection because patients are skittish about injections. So,
Yeah, I think people either use cold laser or they'll use the shockwave. I think shockwave is a little bit steeper price to get into it, but I like the research a little bit more on the shockwave, in my opinion.
the laser is also a bit affordable. It's $40 a session. I don't know, how much would you charge for a shockwave
No, what I'm
session?
saying is Shockwave is the machines themselves are like $80,000. So Shockwave is very expensive, and
Oh,
we charge
for
a
a
lot.
seamless laser, it's about 40,000, I
Yeah.
think.
Yeah,
So,
so I have two lasers. I have the Cutera and the Lunula, but we use them more for like warts and fungal toenails and stuff like that. We don't have any cold lasers, but I've heard a lot of people really like using them. I know Dr. Bromley, he uses one quite frequently in his office. It's kind of like a one room running by itself on a cold laser.
right. I have the Lunula laser too. What's your take on that? How long have
So
you used it?
in my opinion, if the Lunula worked by itself, I wouldn't use my Cutera anymore. And if my
Mhm.
Cutera worked by itself, I wouldn't have bought the Lunula. So I don't think any of them work very, very well, in my opinion. And
Oh,
the one I'm currently doing is a combination of both. A combination of both. If anyone,
I,
I think there's a question here about Shockwave. What I charge for Shockwave is 150 a session, and so per foot. So if it's, let's say, the right foot, I'll do 4 sessions to start, so that would be $600, and then I may add a couple more sessions later on. And we do both the radial and the focused Shockwave.
do you have like a money back guarantee in case the shockwave is not as ideal or as effective as they wish it would have been?
Do you? I don't have a money back guarantee. Do you have it for your laser?
I actually do, but patients don't often ask, so I just put it out there. I had a couple of cases,
Well,
so I just charged the E&M for the insurance, so at least I got that part. But
yeah, so I do guarantee what I do. I can't guarantee that they're going to get better, though. I think neither can you, Edward.
right.
But I'll stick behind it. If they hate their orthotics and they're not comfortable, I'll refund them, because usually they're the ones that are make a mess if we don't do that, right? They're gonna so much bad will instead of goodwill. I refund things. In terms of
Oh, I
Shockwave, um, a lot of times what happens is I'll do four sessions, and I can tell at 4 sessions if they're getting better. Okay, and if they're not getting better, I'm going to tell them, we shouldn't do any more. Let's move on to like a cortisone injection or something else. I tell them straight away. But like you said, they have to be compliant, especially with the physical therapy and doing, especially if they have a lot of Aquinas.
right.
Yeah. Other questions or thoughts, guys? I'd love to contribute, or anyone else contribute to this. Well, thank you guys for taking your lunchtime to do this. Um, I did put up that Google Doc where you can fill in things. If you guys, do you guys want to see my slides or my checklists or anything else that would help you?
Yes, that would be great.
You want to see, what do you want to see? The
The,
slides?
the slides.
Okay, let me show you the slides again. Um, you tell me what you want to see. I'll show you. This is the way I do it. So I basically I just do these. Let me just show you exactly how I do them. Okay, I make them in something called Google Slides, and I have something called Patient Presentations. It's a little folder, and I save them. And the cool thing is, if I want to adapt them, I can change them right as I'm seeing the patient. Okay, and basically I'll pull this up. I'll say, and I always say it like this. I say, Mrs. Johnson, I find it's much better to give like an audio visual presentation so you can understand more about what you're going through. Do you mind if I show you some pictures? And they said yes. And that's where I pull these up, and I'll go over these questions right here. I've just made these questions like, how long have you had your symptoms? I just think that's a good way to divide if they're more of a chronic plantar fasciitis pain, and what treatments have you tried? Okay. I like that because they say, "Oh, I tried that." You're almost like getting in the conversation that's in their head. Okay. And then I also talk about how it impacts your life. And a lot of people, they are afraid of surgery. They don't want to miss out on work, and they can't be as active. And so once again, you're talking like, wow, how did he know that? Well, everyone's the same. And they really want to know what they're going to do. They want to know what they have, why they have it, and how it's going to get better. This is the slide I use. Basically, just pictures I got off of YouTube, Google. Got pictures. And this slide's really helped me a lot if you use diagnostic ultrasound. That really helps me. And then the cost. I play around with different costs. What's it going to cost me? 2,500, 3,000. There's different ways. And then I go down from that and I say, well, you can pay it all up front. No one ever wants to pay that. But then I say, okay, well, you're just going to pay as we go. And so then they're less shocked about the price of my orthotics. That's 550. Okay. And then, oh, just if you see on the side here, some of these are hidden. So some of these hidden ones, as I'm playing around, I hide them because I'm just constantly tweaking these. And that's the neat thing. This hasn't been a one-time, presentation. I've constantly tweaked this. And I have pictures of a lot of different treatments here. This is the shockwave treatment, the amnio treatment, how the inflammation reducing the tightness. I explain about the Aquinas. I talk about Graston technique. These are the different things that I sell in the office for trigger point tools. Different types of ways of loosening with the night splint. Some of the braces that I'll do, and strapping of the foot, different types of shoes, different types of orthotic pictures. I used to show more of these pictures. I'll do these when I'm doing a presentation, recording it, and then some of the advanced treatments like shockwave, amnio, PRP, and surgery. And then it goes down here to the checklist again. So that's basically the presentation. I have these for everything that I treat in the office, but the most common one I use it for is plantar fasciitis and Achilles tendonitis and like fungal nails. Thank you guys. I hope you enjoyed it. We'll be here next month. Oh yeah, next month. What are we going to talk about? I wrote down my notes here. Next month, I was planning on talking about how to do a really quick newsletter for your patients. I have a way of doing like a 3-minute newsletter, and I send it out once a month. And I do that on YouTube. Oh yeah, if you guys want to learn more stuff about YouTube, I'd be happy to share that with you. Let me just show you quickly. Once again, this header, I paid someone on Fiverr to do it. It links to my books. This is the intro video. And here are the newsletters. So I have an Ask Dr. Pelto where people ask me questions. And then here's the newsletter that I did. Basically, this newsletter is 3 minutes long. It's got 1,142 views. It's been a week. And I talk about like our new office that we're opening, a new doctor that we have here, personal maintenance is an article one of the docs wrote, a replay on flat feet that we did a webinar, and then OniFix. And all these links are on the bottom here of this video. And so if you guys are interested in learning more about how to do YouTube and kind of market it, let me know, and that could be a future session. But I wanted to go about this newsletter, how we make this video newsletter, which I think is a lot easier to do than a written one. And I think people will watch something for 2 or 3 minutes more so than reading something. Okay, thank you guys. We're gonna end this webinar and appreciate it. Have a good day. Okay.